Miss Lily, honey, darling. Lily, you're from Mississippi State. Starksville, Mississippi. That's why she's so good looking. Happy Friday, Baylor College of Medicine and friends of Baylor. So there's a rumor I've been nominated for an Emmy. That's not true. But I'm starting the rumor now. If I start the rumor soon enough, maybe it'll happen. All right, so I got a lot of calls about what's going on in China. This giant outbreak of respiratory disease and pneumonias in China. And the concern, of course, is it'll be COVID-23. But that's kind of ridiculous. People forget that after you had a long period of isolation, you get these rebounds. So if you recall, we did not have flu or respiratory virus the entire time we were practicing good public health measures, wearing masks and social distancing. But last winter, after we had sort of loosened things up in the summer before, we had these giant outbreak of RSV and flu. Very bad season last year. And of course, in the fall, we're having one now. Well, this is the first winter after China got rid of all of their restrictive behaviors around public health restrictions. And so, of course, it is totally expected they will have a big outbreak of RSV, flu, et cetera, and COVID-19. The interesting thing with what's going on there, it's mostly children, and it's a lot of mycoplasma pneumonia. Now, mycoplasma is a fairly common pathogen. Many of us are exposed to it. Doesn't cause disease in most cases, and in most cases it's pretty mild. But the biggest problem is that in Beijing, in particular, the strain of mycoplasma that they have is resistant to antibiotics, macrolide antibiotics. And so there is a real problem there, and that's probably what's going on, is mycoplasma pneumonia complicating flu and RSV and COVID, and then having a lot of macrolide resistance against the mycoplasma having macrolide resistance. So that, I think, is what's going on in China, and I don't think it's anything to be alarmed. But another thing that's come up a lot with people asking me is this issue with life expectancy, because life expectancy, for the first time in 150 years, is actually dropping. So remember, life expectancy and lifespan are different. Lifespan is how long you can conceivably live, and you can live up to 80, 82, 88, 90. But life expectancy is, in a population, what's the average age that people live to. And so there's a disproportionate effect if there are children or if there's young people who die, because it disproportionately affects the average. So let's look at life expectancy over time. So this to me is also, I'm always fascinated by this. If you look, this is from 1700s all the way to 1850. The life expectancy for the average human being was about 28 years, 29 years. That was the average life expectancy. And by the way, that goes back thousands of years, with the very first recording of life expectancy. And it's been fixed there for really hundreds of years. And what was that, why is that? And by the way, in 1850, something happened. We started going up in life expectancy to the point where it was linear for 150 years, gaining 3 years of life expectancy every decade until the last couple of years, where for the first time we're seeing a drop. So what's going on? If you think about what was going on in the early 1800s, medicine back then, this was likely to be your physician who'd just come up on a horse, a couple of potions in a box, and frankly, it was a mess. There were epidemics of malaria throughout Ohio, Indiana, Illinois, and Michigan. In the gold camps of California, there was cholera, malaria, typhoid, scurvy. There's all kinds of things that were a problem. And as travelers were going from the East Coast to the West Coast, the new settlers had scarlet fever, yellow fever, diphtheria, smallpox, TB, influenza along the way. So, it was a really tough time. And back then, the only medicines were things that they thought were pungent, like, sulfur and stuff like that. And so the pioneering physicians, these folks, most of them just had potions. You know, they would, if they saw somebody sick, they would predict, oh, they're not doing well, try this potion, and nothing worked. There was no real medicine involved with it. And probably the greatest shortage of all was medical knowledge. Up until the 1860s, most physicians, or most people who were doctors, did not have an actual medical degree. And many of them were just people that called themselves doctors. I'm a doctor, you know, so it was a real problem. They had apprenticeships and things like that, but it wasn't really anything to write home about until people like this showed up, Koch and Lister and Louis Pasteur, in laboratories, and medicine became a science. And life expectancy, because of these things, improved year after year after year. First, the major advances were in public health, protecting the water supply, sort of understanding germ theory, so sterilization practices for surgery, and things like pasteurization of milk. Then vaccines came around and were tremendously important in extending life. More recently, in the 50s and 60s, in 1950s, 60s, in that range, we started making great cardiovascular advances. The statins have had a huge impact, and then cancer immune therapy has had a huge impact. And so what's going on now that it's flattened and actually declining? And what I believe, most of all, is that it's where the advances were due to science. The lack of advances and falling back is sort of the mood of anti-science. So people are not doing things that have been known to be beneficial. So, you know, if you look at it, it's really kind of remarkable. In the United States, we're not doing all that great. This is compared to many different countries. Africa, as you can see, is really, you know, far behind. But let me show you something. This is kind of interesting. We were heading towards a life expectancy of 80 years. And we peaked in 2014 at 78.9 years. And at that point, it stopped going up. It's been flat, and then actually in 2019, because of COVID, it went down. And the interesting thing to me, if you compare us to our peers, our developed country peers, we were sort of in 1980 in the middle of the pack. We weren't the leaders in life expectancy. We weren't the losers either. But we are now the bottom. We are the absolute bottom of the Western countries, the developed countries. And, and we had a huge drop with COVID-19, more than our peers. So, what's going on? A lot of people have attributed that flattening to opioids and gun violence and mental health issues and suicide rates, but actually it is chronic diseases. The disease, cardiovascular and cancer diseases for people in the ages of 35 to 64, they remain the biggest problems. And many of the, if you think about it, in a quarter of the nation's counties, mostly in the South and Midwest, working age people are actually dying at the same rate they were 40 years ago. So in that important age group, 35 to 64, we're not doing well in certain parts of the country. And a lot of these are based on the wealth of the community. So the gap between poor and wealthy communities has really gotten to be huge. And you think about the paradox of that when we're in a country that spends more money on on healthcare than any other comparable country. And then the last thing that is important, our politics are getting really toxic. So if you look at certain communities that really say that they would demand freedom of choice, well, their cigarette taxes are low, their seatbelt laws aren't enforced, and their public health spending is low. And so that's one of the reasons why we're not doing so well. So there's some other really interesting demographics. So this is survival. Again, this is life expectancy. Look if you've got an undergraduate degree versus no degree. So education right here shows that you go from being in the top quartile of survival to the bottom of the pack. So it's kind of amazing to me. If you have a 4-year degree, you are more likely to live 10 years longer than if you don't have a 4-year degree. And just in 1992, that gap was a third of that. So the disease burden in people who do not have a degree is greater. And so what are those disease burdens? Well, This is an interesting graph. It looks at which of the diseases that are causing problems relative to our peers, and which of the ones are beneficial. So anything that's on 0 means we're the same. If it's to the right here, it means we have a higher mortality. To the left means we have a lesser mortality. And in all of the chronic diseases, we are higher than our peers, particularly around cardiovascular disease and things related to obesity, diabetes. But there's also drug overdoses, road accidents, and firearms over here that are higher than our peers. But the only thing that we're better than our peers is treatable, screenable cancers. We do a better job of doing screening for cancer. That's about the only thing. And so again, where is most of this mortality? So this is people dying in their prime, 35 to 64. It's really concentrated in some areas like the Mississippi Delta, Appalachia, certain parts of the Midwest. And it's been something that's been taking place over decades. This isn't something that we just discovered. And it's really gotten a problem, and it was really exacerbated by COVID, because COVID really showed the difference in death rates in socioeconomic status and all these other things I mentioned. But look at another thing, the income gap between rich and poor. So it has gone up. We all know that the gap between rich and poor has gone up about 39%. But look at the death rate. If you're poor, you have a 570% more likelihood of mortality than if you're rich. And that has expanded pretty dramatically. Back in 1980, if you look at deaths per 100,000, 88 more deaths per 100,000 if you are poor, but now it's 448 deaths per 100,000 if you're in a poor community. And if you look at the diseases that cause it's chronic diseases, diabetes, hypertension, obesity, kidney disease. So there was a really interesting study that was published in the journal Economics, looking at 3 adjacent counties, but only based on their sort of political leaning. Are they blue, red, or mixed states? So this is all along Lake Erie. I'm going to talk about this because I'm from this area. I was from Cleveland, Ohio, just down the road. And they looked at Ashtabula, a county right here in Ohio, which is predominantly a red state with both the governor and the legislatures are red. Erie County in Pennsylvania, where there's legislatures red and the governor is blue. And then Chautauqua County, I used to go to Lake Chautauqua all the time when I was in high school. In Chautauqua County in New York, which is a blue legislature and a blue county. And if you just look at death rates between 35 to 64-year-olds, it has really jumped up in Ohio. It's less in the 2 states that are mixed, governed, and blue. And so you begin to wonder, are there policies that are responsible for these kinds of differences? And yes, there are. So in Ashtabula, Ohio, more died of COVID at a much higher rate than in Chautauqua or Pennsylvania, so New York or Pennsylvania. And Ohio is sticking out for all the wrong reasons. 1 in 5 Ohioans will die before they turn 65. The state's life expectancy has dropped from the average to the bottom 5th of the states in the United States, and it's similar to life expectancy to residents of Slovakia and Ecuador. So it's really taken a turn for the worse. And just 30 years ago, Ohio and California had the same mortality rate. So what's happened? Well, Ohio did not expand Medicaid until the start of the Affordable Care Act, where the other 2 states did. Ohio has the lowest tobacco taxes. Ohio doesn't enforce their seatbelt laws. And even though they have a governor who's trying very much to start those policies, the legislature is resisting. So look at this. This is Ashtabula, Ohio versus Pennsylvania, New York. Smoking-related deaths, much higher, lowest taxes on cigarettes. So that's a simple policy. Raise the taxes on cigarettes and limit the amount of smoking. And it turns out if you look at all the states, it's almost not exactly linear, but it's significant in the death rate. With the higher the cigarette tax, the lower the death rate. Then look at motor vehicles. We've talked about seatbelts before. You have to enforce the law. Well, they don't enforce it in Ohio. There's like 88%, or it's something like 20% difference in seatbelt use between New York and Pennsylvania and Ohio. And of course, they have that sort of increase in motor vehicle deaths. And of those motor vehicle deaths, most of them are associated with lack of use of seatbelts. Anyway, again, the reason it's, I think, important to talk about this stuff is policies matter, and life expectancy only works if we use the things that we know that are evidence-based that end up helping save lives. And if you don't want to get vaccinated, if you don't want to wear a seatbelt, all these things, for your population, you won't be living as long as you could. All right, I want to finish today with a bunch of shout-outs. First of all, congratulations to Andrea Dean, Associate Professor of Pediatrics, and Dr. Laura Shirkadamian, Chair of Pediatrics, who are among 84 new members of the American Pediatric Society for 2024. This society recognizes outstanding contributions and leaders in pediatrics. And finally, Dr. Sandesh Nagami and Dr. Seema Lalani, both professors of molecular and human genetics at Baylor, received the Paragon Award for Research Excellence from the Doris Duke Foundation. So that's to celebrate their accomplishments. Anyway, great congratulations to them. Hope you have a great weekend, and I can't wait to see you next week.